Collaboratory series to help us think through and generate new ideas, collaborations, and innovative approaches to preventing preterm delivery and to improving outcomes for babies born too soon. This month, our organizational highlight is the first Black maternal child health CBO in Fresno County, which was established to unapologetically serve the unmet needs of Black and American women, pregnant and birthing people, and babies. This organization is called the Black Wellness and Prosperity Center, with Black standing for belonging, love, affinity, community, and kinship. And you can learn more or donate to their cause from the link in the chat. So for today's collaboratory, we have a fantastic lineup of speakers who you will be hearing from in just a few minutes. First on the agenda is Dr. Bridget Blebu, who did a spectacular job of designing and organizing today's session and will be moderating the rest of it and introducing the other speakers. But I personally am particularly delighted to introduce Dr. Bridget Blebu, who completed her PTBi postdoctoral fellowship with us just this past September, and for whom I had the great honor and great pleasure as serving as primary mentor. So Dr. Blebu is currently an assistant professor at UCLA. She received her PhD in public health from UC Irvine, and she completed her BS in health promotion and disease prevention and her MPH at the University of Southern California, all of course before completing her fellowship here at the UCSF PTBi. As an assistant professor, Dr. Blebu is the recipient of an NIH K-12 Career Development Award, which was funded by the Agency for Healthcare Research and Quality and the Patient Center Outcomes Research Institute, or PCORI. And that K program is entitled the Stakeholder Partnered Implementation Research and Innovation Translation, or SPIRIT K-12 Center of Excellence program. In addition to serving as a K scholar, Dr. Blebu is also directing the implementation science component of a comparative fund of a PCORI funded comparative effectiveness study that you'll be hearing about today. So without further ado, welcome Dr. Bridget Blebu.
Thank you so much, Dr. Cooperman, for that. I'm going to go ahead and share some slides with you all. All right, hopefully you can see my screen okay. But for today's collaboratory, we're going to be focusing on authentic community engagement and centering equity using anti-racism approaches. We hope that after this collaboratory, you will have an understanding of ways to actually center community and stakeholders for intervention development. And we also hope that you'll have a better understanding of how engagement strategies can center in on equity in subsequent implementation efforts. So for the agenda today, I'll be actually providing a brief overview of a comparative effectiveness study, as Dr. Cooperman referenced, called Embrace, which is going to serve as our case study during the panelist discussion. We will also have a dedicated Q&A session towards the end, so I encourage you all to drop any questions you have in the Q&A so we can collate them for the end of the session. This space is definitely meant to be a space of collective learning, so we also encourage you to share any insights from your own work that could be useful for others as well, and you can do so in the chat. So Embrace is a PCORI-funded and comparative effectiveness study that seeks to compare the impact of two forms of prenatal care on the birth and maternal health outcomes of low-income women and birthing people in the Central Valley. And so the first type of care is a group prenatal care program called GLOW, which was actually developed in Fresno in partnership with community and funded by the Preterm Birth Initiative here at UCSF. The second type of care is actually an individual or traditional prenatal care model with enhanced services through the Comprehensive Perinatal Services Program, or CPSP, which is a statewide program that's actually available to Medi-Cal clients. Both of these models actually include strategies to address social needs during pregnancy. And so the aims of Embrace include, first, a comparison of the impacts of each type of care on preterm birth and gestational age. And the second aim focuses on comparing maternal mental health outcomes, including depression and anxiety. And in aim 3, we have a qualitative and quantitative assessment of experiences of respectful or disrespectful care and satisfaction with care. All of these aims focus specifically on Black and Latinx participants through sub-analyses. So the Embrace study team is actually quite large and comprised of a study advisory group, which supports with keeping the vision, community engagement, and ensuring that the study continues to be aligned with stakeholder priorities. The study advisory group includes over 20 different stakeholder groups, ranging from health payers to community members and organizations who were all part of earlier iterations of the GLOW program. The study also includes a dedicated team and resources from Fresno County, who currently implement the GLOW Group Prenatal Care Program. We also have staff and researchers from the Central Valley Health Policy Institute at Cal State Fresno, who have really spearheaded all of this earlier work in developing the GLOW model in partnership with community stakeholders. And finally, we have the UCSF PTBi investigators who lead the comparative effectiveness research components of the study. So as I mentioned, Embrace itself is a comparative effectiveness study and not an implementation science study. And we actually initially planned to focus solely on assessing fidelity or adherence to each of the models of care during the study. But as we were developing the measures of fidelity or the work, it became really clear that the implementation context was quite complex and that there was an opportunity to describe these complexities for a broader audience. So we took a moment to actually consider how we could incorporate more of an implementation focus into the work. For those less familiar, the purpose of implementation science is actually to increase the uptake and sustainability of what we know works in order to improve overall population health. Ultimately, implementation science is really concerned with how interventions are being delivered and why they aren't being delivered. So to date, several scholars, including our panelists today, have called for greater attention to intentionally focusing on equity as part of implementation science. Opportunities for this could include things like leveraging new or existing frameworks to identify drivers of inequity, developing more equitable or equity-focused implementation strategies, and more importantly, bringing an anti-racism lens to the work in order to more rigorously engage with the impacts of racism in the context of implementation. So currently the Embrace implementation component includes 3 aims, which we've outlined here for your review. But beyond these aims, we're really looking into ways that can really refine this work more deeply engaging in equity. And this is the conversation or question we'll actually be exploring today. So now I'd like to take a moment to welcome and introduce our panelists. First, we have Dr. Venice Curry, who is a consultant for community-based organizations collectively working to increase voter engagement, build civic engagement, and sort of capacity through leadership development, and create policy and systems change in Fresno County. The intersection between medicine, environmental, and social justice issues are at the core of her advocacy efforts. She has successfully managed local and statewide issue campaigns on education, healthcare access, air quality, and land use policies as a resident of the Central Valley. Dr. Curry was most recently the San Joaquin Valley Regional Director for Communities for a New California Education Fund. Currently, she serves as Director of Community Engagement for the Embrace study. And in this role, Dr. Curry offers insights as a healthcare provider and advocate for at-risk populations, focusing on Black women in Fresno. Dr. Curry's goal is to ensure that the Embrace study remains true to the intended engagement efforts and recruitment goals. Next, we have Dr. Derek Griffith, who is a founding co-director of the Racial Justice Institute, founder and director of the Center for Men's Health Equity, and professor of health systems administration and oncology at Georgetown University. Trained in psychology and public health, Dr. Griffith's program of research focuses on developing strategies to achieve racial, ethnic, and gender equity in health. He specializes in interventions to promote Black men's health and well-being, and interventions to address racism in organizations and to mitigate the effects of structural racism on health. And finally, we have Dr. Rachel Shelton, who is an associate professor of sociomedical sciences at Columbia University School of Public Health. Here, she is a co-director for the Community Engagement Core resource at the Irving Institute for Clinical and Translational Research. Dr. Shelton is a social and behavioral scientist with training in cancer and social epidemiology and expertise in implementation science, sustainability, health equity, and community-based participatory research. She leads a university-wide initiative on implementation science. So our first discussion topic today will be around authentic stakeholder engagement. And stakeholder engagement actually predates the Embrace study and has had important implications for the study design and recruitment efforts for the study. So beginning in 2015, Fresno County actually commissioned a project to understand the disparities and drivers of infant mortality, and they put forth 4 recommendations from community stakeholders. These included a blue ribbon panel to improve care for African Americans, developing and piloting a group prenatal care program for African American women and birthing people, developing initiatives to address living conditions for African American families, and supporting public health services such as Black infant health. And in response to the second recommendation, the GLOW program was actually developed in partnership with community to expand on the centering pregnancy model with specific strategies to address the social determinants of health and make group prenatal care more accessible. These adaptations included wraparound services, including childcare, transportation, food, and linkages to community resources such as WIC and perinatal wellness. So the Embrace study, which is used or serves as the second phase of the GLOW, aims to actually test its effectiveness among Medi-Cal eligible participants with an explicit intention to oversample African-American participants in response to the AIM report. However, this unfortunately has not come without challenges. Engaging providers has been a real important barrier for the study, and this has had implications for participant recruitment, especially since to date, African-American representation among providers' patient population has been small. So we've attempted to actually overcome these challenges by improving our communication and recruitment strategies and are expanding our geography throughout the Central Valley. And in 2020, during the pandemic, the Embrace study was awarded additional PCORI funding for what we call the enhancement study, which really aimed to develop and to pilot telehealth modifications for GLOW. But during this time, we were also able to re-engage community and gain some important insights that improved our communication strategies and materials to be more relevant to African-American communities. So to start off our conversation, I was hoping we could have Dr. Curry begin with some reflections on the legacy of stakeholder engagement and the legacy of the African-American infant mortality report. So Dr. Curry, can you reflect on the importance of oversampling of African-American participants and some of the Embrace strategies that we've actually used to sort of meet this need and commitment?
Yes, thank you, Dr. Blabu, for the invitation, and also just nice to be with so many excellent people. I want to start with the fact that when this study was commissioned in 2015, it was in reflection to the 87% increase in infant mortality. And in Fresno County, that number was 25 per 1,000 deaths. So that was the infant mortality rate in Fresno. It did trigger a response from First Five and our county supervisor, who then commissioned this study. And so just to give you an idea of what those numbers look like in the world, Cambodia had a rate of 22. Iraq's rate was 21. And so for Fresno, sitting in the middle of California as the 5th largest city in the state, to have a rate that high was astronomical. And that is the reason why oversampling of African Americans is really critical, because that number will not improve unless we are very intentional about addressing what are those barriers and what are those challenges. And so this African American study group really was a reflection of the diverse stakeholders in Fresno. It included providers, it included community members who were active in talking about this issue. And it really reflected a sense that this was a critical juncture and that there needed to be some pivot and some change in the direction The definition of insanity is doing the very same thing over and over again and expecting a different result. And so the idea was that we needed to have some different players in the field. We needed to have some different conversations, and we needed to be much more focused and intentional about figuring out what was happening on the ground. And so that community engagement piece really did ask those questions of people that were most impacted, which is always the mantra of community organizers. You start with the people who are most impacted, you hear and you listen, and then you try to figure out as a partner, what are those solutions that will make a difference? And so along with the maternal and child health expert panel, the recommendations to really dig deeper yielded these recommendations about a blue ribbon panel that again would be comprised of people who worked in the area, but also again, those community voices. And if I could just share one of the comments that really triggered just a gut-wrenching response. One of the ladies shared with us, she said, "No one ever explained to me why my baby died. To this day, I don't know the cause of death." How can you heal if you have no information and you don't have a way of figuring out sort of what went wrong and how to change that? And so we heard stories like this consistently from people who shared they never talked about it. They had not been able to figure out how to manage it. And again, this goes back to the fact that the Black population in Fresno is relatively small, but again, it is the most impacted community for infant mortality. And unless we oversample, unless we actively seek out the voices of Black women who have been most impacted, we can't possibly solve this issue. So I will stop there.
Thank you so much for that. Dr. Shelton, I would love to hear more from your perspective about sort of the broader importance of stakeholder and community engagement, specifically for providing an anti-racism lens or approach in implementation science.
Yes, absolutely. And I'm so honored to be here today on this panel. Thank you so much for having me. So I think broadly, when we think about implementation and implementation science, our goal is really to address these tremendous inequities that we're talking about today, right? Implementation is really about recognizing that there is a whole wealth of knowledge and interventions and strategies, but they're not actually reaching the populations and settings that would benefit from them the most. There's often that gap. And I think implementation has the ability to address these inequities, but only recently have we really named and thought about a lot of these structural factors, structural racism, social determinants that are critical in shaping this gap. So in thinking about community engagement and implementation science and health equity, I think they go hand in hand. I think community engagement is the foundation that has to be in place in order to be successful in implementation efforts. But often what we have seen in the implementation science space is it might be an add-on. We might have already created the evidence base, the strategies. The evidence is not necessarily reflecting those populations who are experiencing all the structural inequities and all the root causes that are underlying them, right? So we have to be thinking much earlier along that implementation pipeline and really identifying when and where, how factors like structural racism is shaping, who has access to the evidence-based interventions in their neighborhoods, in their settings, who is inequitably exposed to disadvantages that accumulate over the life course and that are then resulting in these inequities in the health system. So I think we have to be thinking about these pieces earlier. We can't be waiting until we get to the implementation phase, right? Because community engagement really lays the foundation for ensuring that the priorities and the perspectives of the populations most impacted is considered early on as we're developing them, as we're co-creating them, right? We can't create it and then hope that it works. We are setting ourselves up, I think, for, real challenges in being able to implement and later sustain if we're not thinking about community engagement as the foundation. It has, again, huge implications for feasibility, acceptability, and then even just, again, addressing the root causes that we know are going to matter in terms of implementation. So I see all those pieces as going hand in hand. And it really forces us also to be accountable, right? In terms of thinking about not only the decision making, but also the data. You know, what are we doing with the data? How are we sharing resources? How are we sharing power, not just to the research context, but beyond that? You know, when our study is over, what is left in terms of the capacity building and thinking about the implementation strategies and resources we've brought to the community when our implementation efforts are gone. So again, community engagement is that foundation, but it has huge implications for long-term sustainability and addressing inequities.
Awesome. Thank you so much for sharing that. And it makes me feel a little bit better that we're sort of taking the time now in the context of this study to interrogate these issues and think critically about our role in this space. Dr. Griffith, I would love to know more about this issue that we're facing right now in terms of recruitment and how we can be more equitable with the way that we're reaching our audiences and our intended audiences. And so how can we continue to build out our strategies in this work in honor of the AIM report that Dr. Curry so eloquently reflected on?
Yeah, thank you. And first, let me say thank you to you for organizing this and for the team for organizing this and for inviting me to be part of this. I think I'll just build off of, like, as you said, what Dr. Curry and Dr. Shelton said. I think the way that we try to figure out and engage more of the equitable recruitment strategies that we actually try to expand our reach is doing exactly what Dr. Curry said, and starting with it's actually the difference between sort of community engagement and community-based participatory research. One of the things that you talked about is, you know, community-based participatory research is kind of on the far end of the continuum, where you have community partners who are actively at the table from the inception to the final dissemination of that work, versus community engagement can be a lot of it can mean many more things, where the involvement may be less. There may be less involvement at every step in the process. And so the fact that you have, because part of what we're trying to figure out and part of the question about recruitment and reach is not necessarily going to be answered by finding information in academic journals and so forth. It means engaging people who are in the community who face those barriers or who know the people who face those barriers. So it really does require a different set of information, a different set of voices at the table, and making sure that your system that you understand that our academic expertise is not necessarily going to answer the questions of how do we reach people, that's probably going to come from people who actually have the experience of having challenges being reached. So that bringing those two pieces together is really why we're trying to do this, and where those voices of people who've experienced it and who have that reach into the community can become so important.
Thank you. Any other reflections on this topic before we transition to the next? No? Okay. Go ahead and share my screen. All right. So for our next topic, we've really sort of identified that understanding the context of enhanced prenatal care and implementation in Fresno and the Central Valley has become a really, really important piece to this work. So for instance, so far, we've actually learned that there is considerable provider level variation in whether and how enhanced prenatal care is actually being offered. And that pertains to both arms of our study, the GLOW group prenatal care arm, as well as the individual care and comprehensive services program, which is surprising because this is supposed to be sort of a Medi-Cal benefit available to all individuals in the state of California. And additionally, the Embrace study pilot of telehealth version of GLOW during the pandemic really added another layer of complexity for the providers, facilitators, and participants as far as implementation goes, as well as just experiences during the pandemic and all the new stressors that were unearthed during this time. So all of these factors will likely have an important implication for equitable scaling of enhanced prenatal care. And we've begun to use sort of implementation frameworks to interrogate these factors, but there's definitely an opportunity here to be more rooted in an anti-racism approach. So again, beginning with Dr. Curry and sort of the keeper of our vision, I really would love to know more about how you see equitable implementation and what that would look like in the context of Fresno communities.
Yeah, I think when I was asked this question, I had trouble the very first time, and I still have trouble with it. In part because I recognize that as having worked as a community organizer and sort of gone up the ranks, what I realize is that so much of our time is spent fighting for good policy. And so we invest in this policy fight, we want to see policy change, and then we win policy change. And then we somehow let our guard down and recognize that, oh, it's not being implemented in a way that is centering equity. It's not being implemented in a way that will showcase real change. And oftentimes we're having to relitigate it again. And so as an example, I'll just share that West Fresno has been zoned for heavy industrial since the beginning of time. It's a part of the redlining experience. And so our community fought extremely hard to change our zoning so we would not allow any more industrial zoning. That happened unanimously voted by our city council in 2017. But in 2021, 4 years later, we found ourselves in a position to have to relitigate this again. And we had developers come back and say, I'd really love to expand and I'd really love to have this be rezoned back into industry again. And so that is a fight that is ongoing. And it just highlights the fact that even as we fight, we have to be figuring out what is the implementation strategy? What's the level of accountability? How are we going to leverage what we do know are challenges so that we can bake those in at the front end and be better prepared to fight the fight for equitable implementation? So I don't have a full answer for you. I just know that the fight continues. And if anyone does have the answer, please share because we're working every day to fight that fight. So,
Okay, yes, please.
but I do know that
Fire
it will include equity, and it will include a political solution, because the political determinants of health are really what are shaping our social determinants of health.
Yeah, do any of our panelists want to add to that in any way?
I'll just add, oh, go ahead, Derek.
No, please.
I was going to say, I mean, I love that because I think what's been missing in a lot of our implementation science determinant frameworks is this co-creation that's so grounded in what's happening in the political and social context and the community context. Like, we have grounded our determinant frameworks, and we talk about context. It's organizational context, right? It's leadership, it's financing, it's, you know, incentives, and we forget about how all of that has to be aligned with that broader political context, or none of it matters, right? Just like you're talking about. So I appreciate the need to think about kind of that co-creation of what those determinants are. And again, that's where the community engagement piece and your expertise on the ground is so critical in defining that and specifying that.
Yeah, I was just going to add, you know, I think part of this discussion is really highlighting the need to make sure that we're clear about the ways that we're thinking about racism and anti-racism being operationalized in this context. So looking at racism is trying to have a better understanding of what the barriers are to the problems that we're having, to actually the positive health outcomes that you're actually trying to see. And we think about adding the descriptor of structural, call it structural racism, it really means that we're actually talking about multiple things that we have to then sort of break down. So when you're thinking about, you know, cultural racism and just the norms and so forth that shape the policy and those policy discussions, you have the scientific racism and the kinds of things that are going on in our literature that suggest that, you know, well, it's kind of inevitable that Black women are going to have these experiences, or it's something over the life course. So there's really nothing we can do in a discrete time frame that makes any sense. You have structural, you know, institutional racism within the healthcare system, and then you have it sort of in the community in terms of redlining and so forth. So being clear about when we talk about racism, which thing are we talking about, and how are we going to target, how are we thinking precisely about which part of what are we talking about, and how are we going to address each of those individual parts, and then how they come together. And then the anti-racism is also trying to think about how do you not just get obsessed with and get stuck in trying to figure out the problem, but how do you, with the information that you have, come up with a vision for the goals, objectives, the strategy that you're trying to do to move forward. And so you kind of can't wait until you have a perfect, problem definition. You have to figure out how you're moving forward. But it's also important to kind of balance those two and the efforts to kind of work both ways. And so I think that's the dance of Dr. Curry, of what she's been talking about, is kind of, you're trying to, work on both sides of these at the same time. And that's kind of the biggest challenge.
Thank you so much for calling that out. Dr. Shelton, I think you kind of started touching on this a little bit, but we know that there are some things that can be missing from implementation frameworks, and one of those being these political determinants. But how are some of the ways that folks are starting to reevaluate and sort of add to these implementation frameworks, which there's no shortage of so far, but how are some of the ways that they've been sort of transitioning to be more responsive to anti-racism lenses?
Yes, absolutely. And to Derek's point, I'll tie this back in. I think that that's exactly it, is that a lot of times in implementation science with these frameworks, people say, I'm not going to be able to address, structural racism. That's kind of like beyond the scope of what I can do. But to his point, thinking about the implications that has for implementation, right? If we think about redlining, if we think about residential segregation, the implications that has in terms of what's delivered, in terms of who has access to, to what treatments or programs or exposures, right? And then thinking about really the institutional mechanisms through which structural racism ends up creating and exacerbating and maintaining these inequities, I think is really powerful. It is where implementation science can start to say, okay, let's look at what's happening within our system in terms of, maybe it's who gets referred and not, maybe it's who has access or not, and think about kind of, we've seen it from a quality improvement perspective sometimes, some of the work that's happened in the cancer space, the ACURE trial, for example, where they really flagged and tracked race-specific indicators in terms of who was referred and not, and why, and interrogated that to understand where some of those biases and some of that institutional racism was coming in, and some of those assumptions that have impact on care. So I think part of it is even just in that tracking piece is so essential. We've taken a real race and racism neutral approach to our frameworks and implementation science. And I think that when that happens, we don't understand what's happening in terms of those mechanisms. So some of the ways that I've seen this happen is taking things like the consolidated framework for implementation research, implementation science, which is, really a multi-level framework that looks at these determinants. And Michelle Allen and colleagues have brought really the public health critical race praxis work that Chandra Ford and others have done to kind of say, how is race and racism operating here in terms of what's happening, in terms of, which schools, and the schools that are, more exposed to, historical segregation, that might have, a higher proportion of non-white students. What's happening here that is different, that is related to racism specifically, and how that's operating in terms of implementation. So really calling that out in our analysis and understanding of the mechanisms through which those barriers and facilitators are operating. There's also been really interesting work really thinking about different forms of power, discursive power, really naming like how is the agenda set, how do priorities get set, how do resources get shared or not in implementation research and implementation efforts. So there's some work by Megan Stanton and others that have really tried to identify how power and exertion of power, and who's able to exert power in these implementation efforts, and the implications that has. So we're starting to see it. I think there's a lot more work, but even I think, just to Derek's point, being really specific and at least calling attention to the mechanisms piece in terms of the implications it has is a step forward. And then the other piece I'll just say is really to Venice's point about the accountability and when we think about the implementation piece, right? We often get to the end of our study or our implementation effort and we say, there were inequities, this happened, but we are not being transparent about when and where the inequities are getting exacerbated through either the interventions or the strategies we're choosing. So thinking about, everything from who's offered something and not, who's reached and not, which settings are reached and not, who is so really being micro level in terms of that tracking to try to understand those patterns and then make adaptations and changes in terms of, over time, what needs to happen in terms of implementation to address some of those exacerbations that are happening. So I think there's a lot more work, but again, some tools that we're starting to have to at least think about this.
Did you want to add to that, Dr. Griffith?
Of course. So some of the things that stimulated for me are, often when we talk about things like structural racism, we only look at it as a macro problem, as opposed to the need to do the dance that Rachel was describing of looking at it at a macro level, but also looking at it at an individual or micro level, and how those two are interacting, and how you need to be able to adapt or tailor strategies to the individual needs of people who are experiencing particular challenges and problems, and to not just assume that a one-size-fits-all strategy is going to work. So I think that's the first thing. I think the second is to call out what she was, talking about in relation to power and connecting that to some of the other frameworks that we were talking about. It is important sort of to understand, structural racism as a form of power as we think about what are the places that we're talking about intervening. If we take, the community context that, the context of redlining off the table, and it's not even considered as a point of potentially where could you intervene to do something, that's part of what a power analysis helps you do, and why an anti-racism lens, a structural framework is so important, is because it highlights, well, wait, if one of the key sources of the problem is that people don't have access to certain resources because of where they live, because of the political determinants, because of all these other factors, and we take those kind of things out of the conversation, off the table, it limits the way that we can then think about how we're going to intervene. But we don't even think about it because we didn't even have it on the table to consider in the first place. And so I think those kind of, making sure that we go back to those kinds of tools to look at, well, what is explicitly being considered, and then what are the things that are being, that are not actually on the table, that we need to get that perspective from, say, community partners, from those who've experienced the work, the challenges that we're talking about, having, people at the table who experience that work, and also doing qualitative work to just talk to people about those kind of pieces are really so important, to make sure that that's done systematically and continuously, so that you have access to that information.
Excellent.
Yeah, I really just want to thank both of you for talking so explicitly about power, right? Because as a community organizer, the goal is really to co-create power, to amplify it. And I think about power in terms of physics, and this is the only time I've ever used physics. Had to take it, but didn't really use it. But the idea that an object will stay in motion and will proceed with the same amount of acceleration and on the same course, unless there is an external force that forces it to do something different. And so to me, the reason why we're not going to see change unless we talk about power and are intentional about building power is because this train that's been moving is moving quite fine on its own. It's doing exactly what we expect it to do. And it is the power that's exerted from the outside that's going to really change the course. And so when I think about that, I think about building individual capacity and neighborhood capacity, community capacity, regional capacity. And I think part of when you identify that structural racism exists, you remove that sense of individual and personal sense of inadequacy. You help to connect those dots so that people understand the reason your neighborhood is looking the way that it looks without the normal amenities is not because you deserve less. It is because there's an intentional disinvestment. And so resources have gone somewhere else and are not located in your community. So you don't have parks, you may not have sidewalks and streets. Your air quality may be so much worse, not because you're Black or brown, but because your neighborhood is not the place where people have decided to invest. And so I think for me, making those connections individually with people, and then understanding, oh, if that's the problem, there's a way we can address this that builds the community resources, builds the sense of camaraderie about what is possible. And people, to me, act better when they have a sense of hope. And so for me, all of these pieces are sort of needing to be connected in order to keep exerting that force so that we actually move out of this train track that we're on and get to a better place.
Thank you so much for that. Did
If I
anyone
could
else want to
say
add to that?
One quick thing. I appreciate this. I don't want to make this a love fest, but I appreciate Dr. Curry, you saying that. And I just want to highlight the fact that I know I can speak for Rachel, is that part of the reason that we can talk about power is because we've sat at the feet and learned from community organizers about power. It's not something that was necessarily stuff that we learned in our academic training. We brought it into our academic training through engagements, through learning, through having community partners who were kind enough to teach us about these kinds of things. And we were trying to work collaboratively to bring this into the literature that we have and to strengthen the work that we do. So it is because of our relationships with community organizers that we actually have some sense of these kinds of things. I'm not going to profess that I know what my community partners and organizers do, but that's why we come together and we collaborate together to do that work.
Well, I'm just going to say for them, thank you, because many people maybe have sat in the spaces and not taken it in the way that you have and brought it to the places and the tables that you sit. So I appreciate that.
I appreciate all of you all. And I would love for you guys to each sort of go, because we do have a little bit of time before our Q&A should start. And if you could share just one example from your own work where this anti-racism approach really transformed what you were doing, either in research or in the field. I'll give you a couple of seconds to reflect, and maybe we can start with Dr. Shelton.
Yes, absolutely. So I think for me, it's really what brought me to the field of implementation science. I had done work for several years kind of thinking about a lot of these structural factors, but didn't feel like I was actually doing anything that was having impact, right? It was like, you publish and then, you learn more about that, but it wasn't actually impacting or changing anything in the community. So when I started partnering with community groups that were really equity focused, that were led by, solutions and programs that were led by African-American women who had navigated cancer and were there to really be role models in their community. I wanted to learn from them on, how do we support and sustain programs that are like this, that are addressing the inequities, that are addressing a lot of the underlying factors. And so, they were really facing issues around sustaining their program. They'd been in place 20 years, but had lost about half of their programs when the economic downturn happened in 2010. So for me, it was really about, this wasn't my priority, this was their priority. And how can I bring resources to the table to address and understand how to support and sustain community-led, disparity and equity focused programs. And so I think for me, that's really woven everything I've done in the last 12 years around sustainability and engagement and health equity, and doing that in both funded and unfunded times, right? I think we've had probably more unfunded years together than not. But again, it can't just be about the research, right? It can't be about the grants. That trust and that trustworthiness and addressing those inequities has to go beyond that, right? They're going to be delivering this program, one way with me or without me. So how can I leverage my resources and my privilege and my my decision making in terms of kind of institutional resources to really be able to impact their program. And I think they have really taught me to be really accountable with that. Instead of waiting, even just this past year, we started to learn some things about sustainability and what was happening with institutional racism and partnerships. And they said, we're not going to wait until the end of the study to take action on some of these things. We're not just going to observationally study sustainability. We gave all the data back, and they're doing things to address it, and that to me is the spirit of kind of bringing together the community engagement, the implementation science, and the equity piece, right? Because we want them to be on the ground, being able to lead this work and have the resources to do this and to be able to actually take action from the data. That's the whole purpose. So that to me kind of reflects the intersection of a lot of these issues.
Excellent. Thank you so much for sharing that. Dr. Griffith?
Yeah, so the example that comes to mind is a few years ago, I worked on a program called Practices to Reduce Infant Mortality Through Equity with the state of Michigan, the health department, state of Michigan. And we were focused on Black, white, and Native white disparities in infant mortality. And there was a conversation with some of the Native community members who were talking about how we counted or how we thought about cases of infant mortality. And they simply said, well, you're not counting, like if when you have a case, it's usually only counting the race of the mother and a race and ethnicity of the mother. And so they said, well, you're missing, undercounting essentially half of the cases because you're not capturing, and nobody's asking the race of the father. And so that actually led to us to finally, start to ask that information as a larger sort of working with that state health department to make sure that they started to capture that information, because historically that had not been captured, and that they were severely undercounting those cases of infant mortality. But that came from, again, just the experience of, one of the community partners.
Excellent. How about you, Dr. Curry?
That's a tough question for me, but I'm gonna share that years ago when I was a med student, I was in Kenya working on a maternity ward there and doing ultrasounds and taking care of pregnant moms. And my best friend in Fresno, California was about to deliver her second child. And in a place where we have so many resources, she did not live through childbirth. And that has really impacted me in such a way that, because I knew that it was around equity. I knew that as a second year med student, I would have known what to do in her situation, given the risk factors that she had. And so it really did set me on a course, not only to determine how I would practice medicine, but also those issues that would be important to me. And as a Black woman, for me, I could not be in a space where equity was not at the center, and where access to quality care was not the purpose and the goal and the core of what I needed to be doing and talking about. And so it shaped me in such a way that even when I was a resident, doing internal medicine clinics, if there was a Black male who was of that age that needed to be checked for prostate cancer, I had that conversation. For me, it felt like not only did I need to do what my mom has modeled, and she's 90, still being a community organizer, and my dad, who's 99, who practiced medicine for 50 plus years, I felt like this is the reason and the purpose, and that I have to be the one who has those conversations. I have to be the one who is okay with being uncomfortable about identifying what feels like disrespectful care, even as a med student. And it was a challenge, but it was a place where I felt it's my voice or no one's voice. If I'm not saying it, no one else is going to say it. And so it really has, over the stream of time, been the thing that keeps me connected to feeling a part of the community and understanding that, yes, I live a privileged life in a lot of ways, but I still understand if I get pulled over, and I have been, it's a very scary thing. And so racism is never far from my mind, and equity around healthcare is just another symptom of that racism. And so it is the thing that that keeps me connected. It's also the thing that keeps me fighting for what makes up a nurturing neighborhood versus one that allows infants to die before they reach their first birthday. So.
Thank you so much for that. Any others want to add before we go to our Q&A session? All right. So folks can continue to populate your questions in the Q&A space or in the chat. I think I can see both now, but we do have one question here. And the first is, how do you balance engaging community members with respecting the time and resource ask? And that's given that oftentimes those that need to be centered are resource constrained.
I'll start, or
Oh, go
I'll
ahead.
talk about it from a research perspective. I think that this is a real challenge with the way that our NIH grants are structured, that really don't allow a lot of flexibility. I think we're starting to see, we saw with the COVID RADx grants, some shifts in that. But to be honest, I have used a lot of internal funds and a lot of foundation funding that give a lot more flexibility. Um, in the context of COVID, even, doing the study on sustainability, there were some real issues that came up that didn't relate to cancer or cancer screening in the context of, food insecurity, housing insecurity, vaccine, vaccination. And so it really gave partners, community partners, resources to be able to pivot to address those more fundamental needs that are critical before they did anything related to cancer screening. So I think that when I write a grant, I engage the partners to think about, like, what does equitable compensation look like? We can't just be giving things like gift cards. It has to, if we really want to engage, we have to pay for people's time in a meaningful way, whether that's as a position or whether it's, often I do this through kind of contracts, nonprofit contracts that will go to them directly, and they have the decision making and how to use those funds in ways that serve their populations the best. So that it's challenging in a research context, but I think that we have to shift that. We have to shift that if we really want to do community engaged research.
Thank you. Go ahead, Dr. Curry.
Oh, yeah, I completely agree. And I also think that one of the ways that we've tried to address it is to make sure that we are respectful of people's time and that we actually identify that their time and their investment is important. And so we verbalize that, we then act on that. And then again, it's that sense of creating partnerships versus coming in with the idea that we have answers. And so the partnering and the recognition and respect for what people bring to the table. And it often is really, there's a period of self-reflection when you still think that you may know something that you don't really know. And so that willingness and to be humble and to really listen to people with an open heart.
Thank you. And so our next question, oh, sorry, go for it, Dr. Griffith.
No. I was just going to say, I don't know that I have much more to add other than I think it's just the point of there has to be some compensation for their time. Just like, we're not at the table, frankly, when we're not being paid. So like, why are you expecting, other folks who you're saying their information, their contributions are so valuable and so important? Why are you going to expect, and how are you going to expect them to be at the table when they, this is not their day job. This is the job that they're doing because they love the people, love the community, and the outcomes that you're trying to achieve. And they're taking of their time and of their other responsibilities to invest it in you. So I think you have to figure out some kind of way. And I love the idea of using institutional funds and other kinds of sources of funds, our discretionary funds, because usually we have some form of those, to try to compensate them in some way. The other quick thing I'll say is sometimes it means writing grants with them where they are the PIs. And, so one of the things I used to do, haven't done as much anymore just because of different moves and roles and responsibilities, but is to work with them on grants like community foundations, local foundations, to basically help them write those grants. And I would serve as the evaluator, and they would be the PIs. And so, because they're not necessarily going to compete for, NIH grants, but they will be very successful usually with doing, service related grants, things with community foundations, where they're providing things that are in the wheelhouse of what they do on a daily basis and providing that kind of support. So I think it has to be that sort of quid pro quo.
I'll just say that I love that, and that's exactly what we're doing now, even with local grants, like to Komen or to ACS, where we write the background section. We give them the data we've just collected to demonstrate the challenges, right? And so that's definitely a win-win, and we have that expertise. And the other thing I'll say that I've been thinking about is it requires us institutionally to do a little bookkeeping, because often internally, our organizations are reaching out to a lot of the same groups and not always talking internally. And it creates real challenges, in terms of who are we overburdening, who is always asked, and so also some accountability. We're trying to do this at Columbia right now in terms of who's serving on the community advisory boards, and are we internally communicating about this and how we're compensating. I think that's so important too.
I just want to just jump in there because that made me think about how important the ground game is. And when we talk about grassroots organizing, it's really expanding the field. And, I'm a Warriors fan, so I'm just going to say this, there's strength in numbers. And you just, you want to have more warriors on the field. And so you're needing to do authentic community engagement to really reach those people who are not sort of the known community leaders yet, but they are untapped potential. And so that's another reason why the community engagement strategy is so important for just being on the ground, finding people. We do a lot of canvassing and phone banking, but you really have to go out and search for people. They may be ready to do something extraordinary, but you'd still have to find them and make the space available. So.
I'm sorry.
Excellent.
Just one quick additional thought. And yeah, yes, I love the Warriors too, actually. But my thought is simply that one of the things I don't think is fully appreciated is that successful community engagement from an academic standpoint, for lack of a better way of saying it, is a team sport. We're usually successful, academics who do community engaged work are usually not working alone. We're usually working in teams, or we have other people who can serve who have other areas of expertise, who have complementary skill sets, who can, meet other needs, and we're able to work together in those spaces to do that. When you are isolated, when you are alone, you don't have that ability to leverage the institutional resources to provide that kind of support and to meet those different needs. And so it really does have to be, if you look at the most successful community partners and partnerships, it's because there usually is a team of academics who are doing that work. And there's the institutional commitment, at least within different units, to do that kind of work. It's not just that you have that one, isolated person who's out there trying to do everything, because that usually is just not sustainable.
Right. We actually have two questions that are sort of similar and on this topic. The first is really sort of in the space of, engaging community and building these partnerships between academic institutions. But how do we make this argument more palatable to funders specifically, and sort of them partnering and then supporting this type of work? And then the next is really around our commitments to capacity building. And what are some good examples that you've seen around that?
Yeah, I think it really does take a village. And so Fresno's been really lucky to have some really excellent partners in some of the work that's really been generated because of the African-American infant mortality study. And so I'm thinking of Best Baby Zone, which is a really strong collaboration between our Department of Public Health, UCSF, community groups, local champions. But it's the idea that, it does take people figuring out sort of what's the lane, and then how do you amplify and leverage the work that people are already capable of doing. And then you add that community engagement piece to increase not only the authentic input that you're getting, but you also help get that sense of what are the priorities that may not align with what you think are priorities. So again, listening to the community and figuring out if there's movement and energy around an issue, that's where you want to mobilize and organize people. And so using whatever issue comes up as a priority as a way to expand the dialogue. And so we talked in Fresno, we had a campaign around parks, and it was an interesting place to be because no one really thought it was that big a deal, but it did allow people to talk about land use and redlining and structural racism and zoning. And so it then brought in the health inequities that young people were actually pointing out to us. So there is a way to really structure it so that the community engagement piece informs the direction. And by doing that, you are layering in a support and an interest and an ability to recruit more people to actually be in the space and build that, again, individual and neighborhood and community capacity to really help be the counterweight for, developers who are accustomed to getting basically what they want. So we have found that if building the coalitions, but starting with the ground up as giving us the direction of what the priorities ought to be.
Go ahead, Derek.
Oh, go ahead.
One thought I had around this, and I've seen a real shift in what's happened to the partners that I've worked with around the issues of cancer screening, is that the last couple of years, there's been a real greater accountability at the institutional level. And I can see this, for example, at cancer centers, real accountability in terms of how are they engaging with community partners and demonstrating the impact of that accountability. So that has been a shift in our institutions, and you're starting to see a little bit more movement in terms of their valuing of that partnerships and understanding the broader value it has beyond a specific disease issue in terms of those partnerships. The other thing I think that's happening is that, or the argument that I make is that, we can't just be about these research grants, right? We are not able to sustain those partnerships through these one-off grants. There has to be a bigger investment. And what happens, even us as individual researchers, we are associated with our universities. So when we don't sustain these partnerships, when there are, programs that we implement that aren't sustained, or we disinvest, or, there's something that happens in terms of us stopping when the research ends, it doesn't just have implications for that one partnership, right? It has implications for all of us who represent that university. So our ability to do that work well and to invest in it has implications for all the work that we do, and all of the research efforts that we try and engage with community. And so I think institutions and funders are starting to realize that it needs to go beyond these 2 to 5 year grants, to really demonstrate the value. And demonstrate the, people are talking Derek's amazing work on kind of trustworthiness, right? Building the trustworthiness of institutions.
Yeah, so my thought is, the first thought I had is it ends up being, for me, a leadership problem, that you have to have leaders who understand that what is the role of research and what is the role of the community, and that they're invested in seeing outcomes that are tangible and meaningful, and not just looking at how much of an indirect return are they getting from writing grants in the community. Second thought is, and this is going to sound like heresy coming from a researcher, but we're not going to, if you honestly are thinking about what is going to achieve health equity, it's not necessarily going to be research. It's going to be the translation of research, the implementation of research, the sustainability, and the ability of, whether you call them autonomous organizations, community-based organizations, the things that are in the community to mobilize resources and use the data that we have to address community needs and to, mobilize those kind of political forces that we talked about to achieve change and to actually sustain that change over time. So we have to be a little more modest and realistic about what exactly we're doing in this space, and that we're providing information that's useful and important, but we're not changing policy. We're not implementing policy. These things where our information is actually informing that stuff, but it's not doing it. So if we're really trying to achieve equity, if we're really trying to work with community partners, we have to recognize that their ability to be partners means that we have to actually, if we want them to be partners, then we actually have to support that. We have to build their capacity to be there, to be able to be working with us, or they're going to have to take, frankly, other jobs in a very just pragmatic way. They got to eat too. So unless they're going to come live with you, then you have to actually find ways to support them doing what you need them to do. And so, doing what they feel like they need to do, as well as being able to have the freedom and resources to be able to spend some time doing what you need them to do while they're doing what they feel like they're called to do. So there has to, you have to recognize the bigger picture, I guess is my point, and recognize that if you want those things to be successful, that it does mean a different kind of commitment, a different kind of engagement, and a different kind of understanding of what community partners need to be at the table for you to have that kind of long-term collaboration.
Yeah, I think one thing that we learned in Fresno was the importance of listening to the community and also recognizing, as you mentioned, that the importance of trust. And so part of what we experienced here was when the numbers and the research comes out and tells you sort of, here's the target, here's the most impacted community. If that's not the focus of your work, then you've already sort of put yourself in a place where the work will be misaligned. And so that means that you will lose support from community where you maybe once had it, simply because if you're not starting with the people who are the most impacted and you seem to have pivoted to someone else, that symbolizes that there's not a commitment to actually solving the problem. So that's going to be a problem from the very beginning. And if community is, vocal enough and shares with you, hey, this is problematic, the self-correction is to then say, okay, let me look at this again, and then let me make that pivot back. If that doesn't happen, that does create fissures, that does create issues, and it makes the next round of community engagement that much more difficult, because now you need to then reestablish this will not be like it was before. And frankly, that's part of why I am a part of the Embrace study, because that was our experience as the community in Fresno, with the numbers looking as they did. If the focus wasn't centered on Black women, then it would not feel like it was authentic, and it would not feel like it was designed to be of real help. And so shifting and really having community members vocalize that and verbalize that and agitate and be energized around that has really, in some ways, created a lot more energy and a lot more work and a lot more outcomes that we were really looking for. And so I can say that, Black women are really leading in a number of different ways on this issue. But, in 2015, that was not really the case. That's not how it felt. And part of making the work really align with what community has consistently said is to keep reminding of the research and the way that it really connects what people are telling us is their lived experience. So if people keep saying, when I go to the physician, when I go to the doctor and they don't listen to me, or they disregard me, or their staff is rude, those are experiences that are going to prevent them from seeking prenatal care. So as a provider, you can say, well, they're not following up. But as a person who experiences that, you would say, why would I place myself in a situation that repeatedly traumatizes me? So being able to hear those two and understand what's in the middle and how, if we really want to solve it, we will have to name it, we will have to change it intentionally, and we will have to keep structuring it in such a way that we can still have the conversations and keep trying to get to a place where the real outcomes are that people get quality, respectful care, which is what we say that we really want to see.
Did you want to add to that, Dr. Griffith?
I can have something to say about darn near everything. So this is not going to be, so I have to be careful about that. I guess the only thing I would just say is to recognize that part of the calculus that we do as researchers is honestly part of, and it speaks to some of the tension that Dr. Curry was talking about, is that we have to look at things from a fundability standpoint. So if it seems so insurmountable that, and it's not feasible, if it doesn't appear feasible to the funder, that we say we're going to work with this particular group to do something, and they're like, there's no way that they have the resources to even be part of your study or to do something, it's not going to get funded. So that's why some of these other things that we're talking about have to be part of this larger picture. It's not an either or, as one of my community mentors used to say. It's always a both and. And so we have to figure out how you're going to do that, because if you say that you want to do these bigger picture things and work with the most disadvantaged groups, often those seem to reviewers, who are going to be the ones who essentially decide whether or not you're going to get funded or not, seem like it's too big. and just too insurmountable, so they won't actually support that, versus you have to show the feasibility of doing that kind of work. So that's part of the dance that we have to do. But this is where community partners, come in, and realizing that it's not all about one grant, but it's about a series of grants and a program of research and a team of research, not just sort of looking at things always in one sort of, only single bubble.
And I'll add one point to
Awesome.
that has really come up for me is, and we're not taught to do this well, but is really transparency to community partners we're writing grants with. We kind of get in, we rush it, and then we don't set any expectations. So now, like, I have the conversation of like, there's a good chance this won't get funded. We have 15% chance this might get funded. What are we going to do if it doesn't? What are things we can move for? So thinking about and laying that expectation up front and being transparent about that and what the options are in terms of like what are resources or expertise that we can collaborate on together, even if we don't have a grant to do this. So that has been an important lesson for me as in building that trust.
Great. We do have one question here that's really about sort of education related to community engagement for equity and sort of training our future clinicians, or even just the future generations of individuals who are going to be inspired by this work. I'm thinking of Dr. Curry and sort of our environmental justice fellows work. So how can we think about sort of the training in this space for future clinicians or others who are coming up during these times? Yeah.
Yes, I'm happy to start there, and I appreciate that. So just the Curry Environmental Justice Fellow is really named after my mom. She is the president of Concerned Citizens Concerned Citizens of West Fresno. And she's really the one who led this fight against Darling Rendering Plant. And so the good news is that after a legal battle, a community engagement strategy that included a lot of diverse stakeholders, that this pollution bearing stationary source is going to shut down December of 2023. And that's after 12 years of legal battle. So it's a long-term thing. But part of what we figured out was that not enough warriors on the field. And so one of the ways that we're addressing that is to talk to students as they're coming through. And I'm always recruiting for physicians, so I'm always talking to young people about pre-med, but also talking to med students about what are the ways that they can be good community advocates. And more recently, talking with physicians who are in practice about the ways that climate, health, and equity show up in our communities. And so it's really, for me, it's the pipeline, creating a pipeline of young people who really connect their neighborhood conditions and what they would like to see with their sort of youthful and non-cynical view of the world, so that they have a greater sense of what's possible and can bring that energy to people who are a little bit jaded. So I think of it in terms of reaching backward to make sure that young people understand that there's a pathway for them to be advocates and to do what makes the most sense to them passion-wise, but also to train the people who are peers and colleagues to talk about the combination of things and not to really just view equity or one issue in isolation, but to really see the way that it's connected to the larger pieces of what we experience. And then I look for the older generation to really think about what are the lessons that we should have learned that we haven't quite learned yet, and how do we incorporate all of that in a way that means that I used to say I wouldn't want to see my next generation having to fight this fight. But I'm really proud that my nephew is in this fight also, but I don't want to see his children have to fight this fight. So the goal for me is to create a pipeline that's sustainable, that makes sure that we're not fighting the same fight all over again in the next 20 years. And so however that translates into more physicians, more people who understand the connections between political and social determinants of health, that's the way that I envision moving forward to a place where we can all live and thrive and have equity.
Thank you so much. Others?
Sure, that's beautiful, Denise. Thank you for sharing that. I'm so honored to hear about that history of that. I think, Derek and I have done some writing and thinking about this together. And I think for me, one piece that's really useful is thinking about kind of moving the dialogue along, because I think sometimes people, especially in the implementation science space, who either haven't done community engagement or health equity work, get overwhelmed. And so, the idea is not, we're going to try and do it all here, we're going to all solve it, but really thinking about how can we reflect and do this better. And I think especially for researchers, the piece you talked about, Bernice, in terms of kind of the humility, right? That we are coming to communities, not with all the answers, not with all the evidence, right? That there's some humility and accountability to the work that we're doing. And, really just having people kind of reflect on not only the research, but, everything we do in terms of our research institutions, in terms of how we're thinking about community engagement and thinking about health equity, as we're reflecting, as we build our teams and our labs, and, really just reflecting in general in terms of doing the work better, and it may relate to our research, but I think it has to go beyond that to kind of have the impact that you're talking about in terms of, connecting the dots and making sustainable change.
Yeah, my thought is, I think it's important for the next generation of, whether it's physicians, healthcare professionals, or folks who are in this fight and in this work, to really be honest with themselves, to understand the relationship between the problem that they've identified and the work that they're actually trying to do. And so, and part of the reason that I end up being a real stickler, part of it's just because I'm a very literal person, but that's my curse. But the other part of that, the way that actually ends up helping me is when people are really being precise about, are you really going to address some particular healthcare disparity, and you're really looking at the difference in quality of care, access to care, and sort of uptake of information, or are you actually trying to address some kind of determinant of health or some kind of problem outside of the healthcare system? And what is the possibility that the research that you're doing is going to translate into something that actually has some kind of meaningful impact and change? And so being honest with yourself that, and not sort of overselling, that my series of studies, are going to, solve healthcare, health disparities, that are going to, create health equity, that, we're going to be able to create health equity in our area by getting funded, these 3 grants funded. Like, you have to be kind of a little more modest and not oversell that, because we've, again, sold this thing. There's an interesting paper that was written about 12 years ago, I think now. It's called, essentially part of the title was about the health disparities industry. And it was about, I think it was like the health disparities conundrum, but it was Mary Shaw Ridley and I think Charles Ridley. But basically they were talking about when this attention to health disparities sort of came on the scene, that one of the only thing that we've actually seen a lot of success in is basically the massive influx of resources that have gone to academic institutions to build this healthcare disparities research infrastructure, but you haven't seen a commensurate impact on the actual health outcomes that these are all supposed to be addressing. And so it suggests that there's something amiss about how we're actually doing and what we're doing. And there's a need to be more modest about, again, what research is going to do versus what the interpretation, implementation, sustainability of the research is going to do. And so that kind of, transparency and honesty with ourselves, because I think we go into it thinking, okay, well, if I do my little part, then that's going to save the world. We've got to be a little more modest and realistic about what exactly our work is going to do, not to minimize it, but to at least be honest with others and ourselves about where we fit into this larger picture.
Great. Yeah, I think we've all kind of touched on this. One last question here, but if anyone has anything to add, I'll just go ahead and read it. So concerning sustainability, how do you navigate redlining that occurs in policies that prevent public funds to be used for racial-specific or race-specific work? Oftentimes, local initiatives are funded for a few years while sustaining Black-specific work. and that becomes difficult under these conditions, and maintaining public funds comes at a loss of the authenticity of doing this work specifically for Black populations. So how can we navigate that tension?
It depends on the institutional commitment. So I think that's part of the answer. This is why, as Rachel was saying earlier, you know, our ability to mobilize and utilize and leverage institutional funds that may not be bound by the same rules that you have like public funds, those kinds of things can be an important tool to be able to utilize. But it means looking at other sources, looking at private sources. One of the centers that I'm connected to created as part of their center, essentially like a philanthropic arm. Even though it was an NIH funded center, they had an like a philanthropic advisory board. They had a nicer name for it than what I'm describing. But what they basically said is that there are a lot of things that are going to come up in the context of trying to address these kind of health inequities that we're not going to be able to address under the scope of the research that we're doing. But we can, you know, basically have people at the ready who are representing or who know how to reach out to local foundations or to the foundation world, private donors, private, you know, folks who have resources, and they can be the ones to help address those kinds of things or leverage that to be able to mobilize resources to do that. So that kind of creative thinking about utilizing other sources, in addition to, of course, the obvious thing of trying to fight the policy that says that that's a, you know, that you can't use that. So that's, you know, beyond that, but, you know, in the short term, trying to think about those kind of issues as well.
Yeah, the one thing I would add is to think about just the importance of voting and the civic engagement piece. That for, you know, what we've found is, you know, Board of Supervisors control so much of the public health dollars, and recently turned down in Fresno, recently turned down an opportunity to study the effects of climate health on communities here in the one of the most polluted places in the world. So it didn't make a lot of sense. But again, that political determinant, that political will, we have to counter that with every available option. And one option is to vote and to create those elected officials that will be better advocates. And so as part of the strategy, besides building individual and community capacity, is also to have levers of power that we don't currently have access to. And so building that bench of elected officials who can also weigh in, who can also be on the community side and be advocates for, even if it's, you know, if it's public dollars that need to be invested in certain places. City council make a lot of those decisions about basic things like infrastructure. And so how do we impact that? Well, sometimes we have to elect different people. And so the civic engagement strategy, we still have to keep utilizing because we have found that it works. So I see all the pieces, and I feel like all of these pieces are needed options for us in order to get where we need to go.
Thank you so much for that. I'm going to go ahead and close this out. Thank you to our panelists who shared such important and inspiring insights on this topic. I really, really hope that this conversation inspires us all to continue looking for authentic ways that we can do this work and ensuring that the success of our research is connected to the success of the communities that we're partnering with. I also want to thank all of the equity scholars, particularly those of color who came before us and created a pathway and a toolbox for those of us who are newer into this space to really engage in dialogue. Thanks to the Embrace funders and research team and all the community members for all the hard work with recruitment, study engagement, and all of this deep thinking that we've been doing around these issues. And thanks to Dr. Cooperman for trusting me to ask these questions in the space of the Embrace study. So I'll go ahead and pass it off to, oh wait, one more thing. There are resources available to you all. If you go back to the website where you RSVP'd, you can, for PTBi, you can find a whole list of resources that we provided related to this topic. So now I'll pass it to Solaire Spellin, but thank you all.
Thank you all for joining our May Collaboratory. If you want to stay connected and continue to be in community with us, we have a couple of events that are coming up that you should definitely check out. Next Wednesday, On May 11th, we are hosting the first virtual Rally for Black Birth Justice. This is a virtual event where we will be discussing concrete solutions, expectations that Black mamas have, and overall recommendations on how we can do better and ensure Black families experience happy and healthy births in our state. This is about action and the time is now. So please RSVP. We even created a TikTok to promote this event. So I really hope to see folks there. And next month in June, we are so excited to announce our first in-person outdoor event that will be hosted on the last Saturday of June. In partnership with the San Francisco Department of Public Health and Expecting Justice, we are helping to host Black and Beautiful, a family reunion at the San Francisco Bayview Y. We're utilizing Quesada Street in San Francisco to invite Black families to come out and celebrate. There will be free food, goodies, including warrior swag, free haircuts and hair braiding demos. There'll be live music, bouncy obstacle courses, family games, and even a dominoes game tournament. So you definitely don't want to miss this event. Please save the date. That's Saturday, June 25th. Thank you again for joining us. Have a great day, and we'll see you next time.